Let's get started. I'd like to welcome everyone to today's webinar. I am the Vasculitis Foundation webinar host, Kathy Olewski, and I'm also a patient living with MPA vasculitis. These webinars are part of the Vasculitis Foundation's commitment to patient education. In today's webinar, which is what you need to know about Uplizna with Dr. Guy Katz. After we finish this webinar today, there will be a recorded version on the Vasculitis Foundation's YouTube channel, and everyone who registered today will receive an email with a link to it as soon as it becomes available. And now I think all of the housekeeping is done, so we will bring the screen back on and share our guest speaker with you today. Dr. Guy Katz is a rheumatologist and clinician-investigator in the Mass General Brigham Division of Rheumatology, Inflammation, and Immunity in Boston, Massachusetts, and an instructor in medicine at Harvard Medical School. He's a member of the MGH Rheumatology and Allergy Clinical Epidemiology Research Program, MGH Rheumatology Vasculitis Program, and MGH IgG4-related disease Center. And so welcome, Dr. Katz. We're so happy to have you here with us.
I'm thrilled to be back. Thanks very much to Kathy and the organizers for having me. And I am excited to be able to talk about this today. Let me see if I'm able to share my screen here.
Hopefully I just made it work.
There we go. Are you able to see that, Kathy?
Yes.
Excellent.
And if you have any disclosures, if you would give us those.
Yes, I will, absolutely. So the talk today is going to be about specifically Inebilizumab, which the brand name for that is Uplizna, which is the FDA-approved treatment for IgG4-related disease. But I know that IgG4-related disease is a topic that there hasn't been that there's still a lot of education to be done on. So while the talk is really focused on that, I'm happy to answer questions about IgG4-related disease more generally, if that would be helpful. I do have an important disclosure here, which is that I've consulted for and advised Amgen regarding this particular medication, Inebilizumab, for IgG4-related disease. That being said, everything that I'm going to be discussing is publicly available, and I'm not discussing any data that haven't been published. So everything is Amgen has had no role in preparing any of these slides. This is all my own thoughts, but I wanted to be perfectly honest about the fact that I have consulted for them. I have some other disclosures that are on the slide here that I do not believe are related to what we're going to be discussing. So the objectives for today are to provide a very brief overview of IgG4-related disease. I will mention that just an overview of IgG4-related disease could be a full day event. So I'm not going to be able to go through everything there is to say about IgG4-related disease, but hopefully just give a very brief overview. We'll discuss the mechanism of action of Inebilizumab, which I'm going to refer to as Inebilizumab moving forward, but just so we make sure that the terminology is clear, Inebilizumab and Uplizna are referring to the same thing. Uplizna is the brand name, and Inebilizumab is the generic version. We'll review the evidence for Inebilizumab in the treatment of IgG4-related disease, and we'll discuss the side effects and the safety considerations surrounding the use of Inebilizumab and what that means for you as a patient as you think about using this medication and what else there is that's involved in that. So first, what is IgG4-related disease? IgG4-related disease is a systemic autoimmune disease. You can think of it as very similar to many of the other vasculitis syndromes that we talk about in the Vasculitis Foundation, like ANCA-associated vasculitis, giant cell arteritis, or like other autoimmune diseases like lupus or rheumatoid arthritis. Very similar to those. It is a systemic autoimmune disease that can affect a lot of different parts of the body. The reason we call it IgG4-related disease is that back in the early 2000s, researchers when this disease was first being described, researchers found that a large majority of patients with the disease have elevated serum IgG4 levels in their blood, and also a disproportional increase of IgG4 positive cells when you look at the cells in tissue biopsies of areas that are involved by IgG4 related disease. I will mention that IgG4 is a normal part of our immunology. Everyone has some IgG4 in their blood. I shouldn't say everyone. There are situations where people don't have IgG4, but in healthy immune systems, there's usually a certain amount of IgG4, and in people with IgG4 related disease, that can be elevated. Though it's important to recognize that not everyone with IgG4 related disease has elevated serum IgG4 levels, and much more importantly, not everyone that has IgG4 levels that are elevated in their blood has IgG4 related disease. In fact, the opposite is true. Most people who have elevated IgG4 levels, particularly if they're only mildly elevated, most of those people do not have IgG4 related disease. So it is an important distinction that the IgG4 level does not mean IgG4 related disease. And how does it present? It presents with inflammation of typical organs, and sometimes it can present atypically as well. But wherever it's involved, it tends to lead to organ enlargement, often with kind of mass-like inflammatory lesions, which can be quite concerning to a lot of people and lead to concern for cancer because some of these mass lesions can look very similar to cancer. But it's not a cancer, it is all inflammation. There's no cancer or tumor cells when you actually biopsy those masses under and look at them under the microscope. And the other way that it can present is with organ dysfunction from that inflammation in the organ. So just like in ANCA-associated vasculitis, if the kidney is inflamed, the kidney might become dysfunctional. The same thing can happen in organs that are affected by IgG4-related disease. And on the right side of the screen, I've listed some of the more common manifestations that we see in IgG4-related disease. Autoimmune pancreatitis was the first manifestation that was recognized as a manifestation of this disease, and was really what led to us recognizing that this is a multi-system disease. Salivary and tear gland enlargement, the technical term for those are submandibular, parotid, and lacrimal glands. The lacrimal glands are the tear glands, and the submandibular and parotid glands are the salivary glands. And they can become quite enlarged in people with IgG4-related disease. It can involve the lungs, the airways, which can cause shortness of breath, cough. It can lead to kidney inflammation. And importantly, this is the Vasculitis Foundation. It is a vasculitis. It commonly involves the aorta and the coronary arteries in particular, though other types of blood vessels can also be involved. This is a slide that sort of depicts what is happening at the immune system level in people with IgG4-related disease. And this is something that's hard for even me to understand. So I don't expect any of you to understand it. But I do hope that the one thing that we can get out of this slide is you can see that there's in multiple areas of the slide, there's reference to B cells. On the left side, you can see naive B cells. In the middle, activated B cells, or uh, more mature version of a B cell called a plasmablast. And then on the right side, class switched B cells. It would take forever to go into all of the immunology here. And ultimately, I don't think all of the specifics matter all that much, but I did want to point this out because as we talk about inebilizumab, it targets these particular cells. So I put this in here just to emphasize that these B cells and cells related to B cells are really, really central in what happens in people with IgG4-related disease. And we think that they're driving the majority of the inflammation that's happening in this disease. So that's what led to the concept of thinking about targeting these B cells as a treatment for IgG4-related disease. So that brings us into the actual drug. What is inebilizumab? So inebilizumab is a monoclonal antibody against CD19. Monoclonal antibodies are used in a lot of different autoimmune diseases, including in various vasculitis syndromes. And CD19 is a cell marker that's present on B cells and related cells. And we'll talk about that more in just a second. Inebilizumab has been FDA approved for a few years for use in a neurologic disease called NMO spectrum disorder. And more recently, just in April of this year, it was approved for use in IgG4-related disease, which is very exciting because it is the first and only FDA-approved treatment that we have for this disease. So let's take a second and just think about how antibodies work in general. And this is just part of our normal immune system. Everyone has antibodies. And this is what antibodies look like, this Y-shaped structure. And the top part of the antibody on the screen is the part that's supposed to recognize a certain target. The bottom is recognized by our own immune system so that it can do something. And we'll talk about what that is in just a second. So this is an illustration that gives kind of an overview of how antibodies are supposed to work in just our normal physiology. So we're not talking about any medications at this point. We're just talking about normal immune system. And here you can see on the left side of the screen, there's a bacteria. This is supposed to represent essentially any infectious agent that comes into our body. And our immune system was really designed to be able to find and eliminate infectious agents. So here we have an example of a bacterium. Similar things happen with other types of infections as well. And all of these, every infectious agent has certain markers that are present on their cell surface. So what happens is, in the middle of the screen is an example of an antibody that would be present in someone's blood or lymph nodes or somewhere. And on the right side is just representation of the rest of the immune system. And what happens is when an infectious agent is present, then an antibody that recognizes that specific marker on that infectious agent's cell surface. And that antibody binds to the infectious agent. The reason this happens is then it is supposed to signal to the rest of the immune system, this is foreign. This is something that isn't supposed to be there. So again, the top part of the antibody is the part that recognizes some specific, it's called an antigen, essentially anything that's recognized by the immune system as something that's foreign, something that shouldn't be there. And when that binding happens, it triggers the other immune cells to recognize the other part of the antibody, the lower part of the Y-shaped antibody, and that part of the antibody triggers the rest of the immune system to come in and say, because this is a foreign material, it's not supposed to be there, we need to kill it. So the rest of the immune cells have what they need to be able to kill the bacteria or whatever other foreign substance is there. And it's just kind of a broad overview of how the immune system is supposed to work and how antibodies contribute to doing that. Moving back to Inebilizumab is an antibody. It's just an antibody that's generated in a lab rather than an antibody that's generated by our own immune system. And the way it's designed is that the top portion recognizes CD19, which I mentioned in the previous slide is a marker that's present on B cells and cells related to B cells. The bottom part of the antibody is exactly the same as the other antibodies in our body, which is just that that part of the antibody gets recognized by our immune system. So back to the same schematic, except this time the antibody is Inebilizumab rather than an antibody that is supposed to target a bacterial cell surface marker. So here, Inebilizumab recognizes CD19. And you can see here that on the left side of the screen, we have a B cell, and the B cell has CD19 on the cell surface. So what happens is the antibody, Inebilizumab, recognizes that CD19, just like it would if this were a bacterial marker and that's what the antibody is supposed to recognize. And just like before, that triggers the rest of the immune system to come in, and it tells the rest of the immune system, this B cell is foreign. It's not supposed to be there. So even though it's a B cell that's coming from your own body, this is not truly a foreign substance. It tells the immune system, this is foreign, it's not supposed to be there. And as a result, the immune system kills the B cell. Now, if you do this to a person with a healthy immune system, then what you're doing is you're getting rid of their own B cells, which suppresses a part of the immune system that's really important. So that will come up later on in the talk as we talk about some of the side effects and risks of the medication. But the reason we use it in IgG4-related disease is, as we discussed a couple of slides ago, these B cells are really, really central in what's causing and driving the inflammation that leads to the disease. So by targeting these B cells, we're really addressing that inflammation at its core. So this medication is considered part of a class of medication called B-cell depleting agents. B-cell depletion is when we use these antibodies to find B cells in our body that are supposed to be the B cells that are contributing to autoimmune disease, and it eliminates those B cells using the body's own immune system. So I do think it's important to recognize that even though this medication and other similar medications are really good at eliminating B cells from the blood, they don't eliminate all of the B cells from the entire body. We know from similar medications that if you give someone a B cell depleting agent and you check the B cells in the blood, even within days, the B cells in the blood will be gone. But there's still B cells in lymph nodes and in other sites of inflammation and the bone marrow that can persist for a really long time despite continuous treatment with these medications. Um, Now, many of you might have already encountered other types of B cell depletion. Some of them are used in other types of vasculitis. The most common one by far is rituximab, and here I put some biosimilar brands that are kind of the same idea as rituximab. And a few others, obinutuzumab, ofatumumab, and ocrelizumab. These are all different types of B cell depletion, and inebilizumab is on that list as a B cell depleting agent. Um, so how is inebilizumab given? This is again similar to many of the other B cell depleting agents that we use. It's given as an intravenous infusion, meaning you need to be in an infusion center and you have an IV placed, and it's given through an IV bag. It's 300 milligrams per dose. That's not really something that affects you all that much, but it's a pretty standard dose. And it's given as an initial 2 doses that are separated by 2 weeks. And then additional doses can be given every 6 months or so. But the timing and duration is something that's kind of individualized, and we'll talk about that a little bit more later on in this talk. There's no universal guidelines that say how long we should be using inebilizumab, and it's going to take time for us to have a consensus on how it should be used, considering it's only been approved for a little over 6 months. So there's still a lot that we need to learn about how we can use it long term. But I would mention that this dosing is very similar to rituximab, where rituximab is often given as 2 initial doses separated by 2 weeks, and then very often given every 6 months or so. Again, on a case-by-case basis, it can be a little bit different. So the next question is, now that we know a little bit more about what inebilizumab is and how it works and how we give it, the question is, does it actually work? And based on the fact that it's FDA approved, I think you can assume that it does. But I'd like to challenge that and make sure that we agree, as of today, that the data really suggests that this is an effective treatment in IgG4 related disease. So we've known actually for a very long time, for over a decade, that B cell depletion is effective in IgG4 related disease. And before this year, the medication that we were using to treat this disease most frequently was rituximab, which is a B cell depleting agent, as we've talked about. But rituximab was never studied in this disease using a large international placebo-controlled trial. In fact, the first trial to do that was the trial that looked at inebilizumab. It was called the Mitigate trial. That was the name of the trial. And it was published about a year ago. And it was really the trial that led to the FDA approval of IgG4 related, or of inebilizumab in IgG4 related disease. So let's take a look at the trial in a little bit of detail. So the patients who were enrolled in the trial were patients who had IgG4 related disease. They had to fulfill classification criteria for the disease, and they had to be flaring. So these are patients who had active disease at the time that they enrolled in the trial. It could be a new diagnosis, or it could be someone who's had the diagnosis for a long time, but they had to have active disease. They had to have a recent flare. And they were treated with glucocorticoids, which is prednisone in most cases. And they were able to be on prednisone for a few weeks before they started the trial. But after they started the trial, they had to taper off the steroids completely within 8 weeks. So that was a pre-specified taper. Everyone had to be off prednisone by 8 weeks. If they needed to increase the prednisone because their disease was active, then that meant they had a flare, and that was considered a flare as part of the trial, which is really the outcome. They were trying to see how many of the patients who were in the trial had a flare. And the patients who enrolled in the trial were randomized, meaning they didn't know what they were getting. Their treating physician didn't know what they were getting. The trial sponsor didn't know what they were getting. No one knew what they were getting. And but they got either placebo or inebilizumab with the same dosing strategy that I described before. They got initial doses, 2 doses separated by 2 weeks, and then one more dose at week 26, which is 6 months. The primary outcome was at week 52. So the outcome was the time to flare, how many people were having flares during the time that they were being treated. And this is the main image that describes the results of the trial. The way to interpret this graph is on the vertical axis. It says the probability that the people in the group were had no flares. In the horizontal axis, it's the number of days that they're in the trial. So essentially, what you're looking for is the lower the curve is, the more flares there are. Every time the curve has a step down, it means that there was a flare at that point, and the larger the step, the more flares there were at that time period. The blue curve here is the placebo group, and the yellow curve is the inebilizumab group. And you can see that there is a massive difference between the two curves, which shows that the people who were treated with inebilizumab rather than placebo had much, much fewer flares than the people who were treated with placebo. And this numerically can be shown on the right side of the screen. They describe a hazard ratio of 0.13. And that's a statistical term that essentially can be interpreted as the risk of a flare over the time period of the study was reduced by 87% in the people who were treated with inebilizumab compared to the people who were treated with placebo. So an 87% reduction in the risk of flare. So this is an overwhelmingly positive result and is sort of incontrovertible that inebilizumab does work in IgG4-related disease. There were a couple of other things that they showed in the trial, which are to be expected based on the way that inebilizumab works. The left side of the screen shows what happens to people's B cells. These are CD20 positive cells, which are CD19 and CD20 are the two most common markers on B cells. And you can see again, the blue is placebo, the yellow is inebilizumab. And you can see that essentially immediately after treatment, the B cells dropped to the bottom of the curve, essentially were eliminated from blood just as we would expect, and they remained low or undetectable essentially the whole time. And then on the right side is the IgG4 levels. And we'll talk a little bit more about IgG4, I assume, in the questions. But what we find is that in people with IgG4-related disease who have elevated IgG4 levels at the start of their disease, we find that the IgG4 levels do track fairly nicely with the amount of disease activity that they have. And here you can see that the placebo group had essentially no change in their IgG4 levels across the study period, whereas the people treated with inebilizumab had a nice progressive decrease in the IgG4 level. So that all sort of tracks with the idea that the inebilizumab was doing what it was supposed to. It was depleting the B cells, and it was reducing the IgG4 level, which corresponds with the idea that they were having less flares. So Mitigate really gives us overwhelming evidence of efficacy of inebilizumab in IgG4-related disease, and that's the reason that it was approved by the FDA in April of this year. Now, a big question that comes up frequently is inebilizumab is a newer medicine. People are not as familiar with it. Rituximab we've been using for well over a decade in multiple diseases, actually close to 2 decades. But has never been studied in this way in IgG4-related disease. So unfortunately, no head-to-head studies have ever compared the efficacy of inebilizumab and rituximab, and I don't know that this will ever be done. Hopefully it will. It would be really interesting to see those results. But the reality is, from our experience using both and from the Mitigate trial, and from other studies that we've done in IgG4-related disease, we know that both of them are overwhelmingly effective. That's the good news. We have options that work really, really well. But there are some differences between inebilizumab and rituximab that come into play as we decide which one of them to use. And I've listed them here, but we'll go into all of them in more detail. One is the difference between CD19 and CD20. We talked about how those are two markers on B cells. Inebilizumab is humanized. Again, we'll talk about what that means. It's also glycoengineered in a particular way. And then there are cost differences. So we'll talk about all of those over the next few minutes. So I've shown this slide already, the idea of B cells, which B cell depletion, which is meant to target and eliminate B cells that are contributing to autoimmune disease. And I listed all of these other examples of B cell depleting agents. What I didn't show before is that all of these target CD20. So the difference between inebilizumab and all of these other agents is that it's actually targeting a different marker on B cells compared to all of these other agents. And here's what that means. So this is a schematic of the different cells that are part of the B cell lineage. Now, there are many different types of immune cells in the immune system. B cells are one of that type, but among B cells, there's a wide range of different cells that are related to them. And it starts from stem cells that are in the bone marrow and essentially uh, 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 create and lead to the formation of the more mature B cells. And then all the way on the other end is plasma cells and plasmablasts, which are the cells that produce antibodies. So when we measure antibodies in the blood, those are being created by plasmablasts and plasma cells, and those come from B cells. So this is a spectrum, and cells essentially go through this whole maturation process. And what you can see on the bottom of the screen is that CD19, shown in blue, is present on a wider range of B cell and related B cells and related cells, ranging all the way from what are called pro B cells and all the way through some plasma cells. Whereas CD20 is present on a narrower range of B cell subsets. So the idea with targeting CD19 is that you get a deeper degree of B cell depletion, and you also get some of those more mature plasmablasts and plasma cells that are contributing to the autoimmune process in a slightly different way than the rest of the B cells. So the hope with targeting CD19 as opposed to CD20 is that it might be somewhat more effective, perhaps lead to more B cell depletion, which could lead to a longer duration of effect after it's administered. And because it's targeting some of those later cells, potentially also working a little bit faster than drugs that target CD20. Again, this is all theoretical. The two have never been compared against each other, certainly not in IgG4-related disease. So there's no way for us to be able to say that with any certainty. But those are the theoretical reasons to think about targeting CD19 over CD20. The second thing to think about is immunogenicity. And in my experience, this is the difference between inebilizumab and rituximab that most patients find to be the most important. Whenever we administer an antibody that's made in a lab, there are different ways that it's made, and part of it, most monoclonal antibodies that we administer, have some portions of them that are made from animal proteins, just because of the process of how it's made in the lab, and that it's easier to be able to make it that way. So most antibodies do have some amount of non-human protein in there. And because it's non-human, our immune system has the potential to recognize it as foreign, to recognize the actual drug as foreign. The more non-human protein there is in the antibody, the more likely it is to be recognized by the immune system, which is also considered, the term for that is immunogenicity. And here you can see a schematic that on the left side is an antibody that's 0% human, and on the right side is an antibody that's 100% human. And as you add more human and you subtract the amount of non-human protein in the antibody, the potential for immunogenicity is lower. But what does that actually mean to you as the patient getting the medication? Again, immunogenicity results from it recognizing the medication as foreign. The immune system recognizes the actual medication as foreign. And what happens with that is the immune system can clear the medication because it recognizes that it's foreign, which increases the likelihood that the medication could fail after you use it for a while, because essentially the immune system recognizes that that medication isn't supposed to be there, and it eliminates it from the body before the medication is able to do what it needs to do. But more importantly, it's these non-human protein parts of the drug that lead to a large proportion of infusion reactions. And any of you who have been treated with rituximab in the past might recognize that infusion reactions are actually relatively common. Most of them, fortunately, are minor, but they can happen, itchy throat or a little bit of wheezing, maybe some hives, not uncommon at all. Rituximab is chimeric, so that's the second image on the schematic on the left. Because of that, it actually does have a decent amount of immunogenicity, and that explains why those infusion reactions are relatively common. Because of that, it needs to be given very slowly, usually in an infusion that lasts about 4 to 6 hours. And then after you've been given a few doses, if it goes really well, sometimes they do it faster than that. Um, but that is, in my experience, one of the biggest challenges that patients find with rituximab is just how long they have to be in the infusion center and how frequent it is that they have infusion reactions. Even if they're not bad enough that we have to stop the drug, they're still quite bothersome in many cases. And Inebilizumab, on the other hand, is humanized, meaning that there's less than 10% of the protein in the antibody is non-human. Um, and that's really good. We have very few medications that are fully human, so for it to be humanized is a step in the right direction for sure. Because of that, infusion reactions are actually relatively uncommon with inebilizumab, and it can be given as fast as about an hour and a half, which is a big difference compared to rituximab. So when I've spoken to patients about the options of rituximab and inebilizumab, most of the patients I've spoken to have been very excited about inebilizumab, mostly because it's a much shorter infusion. The third difference that I mentioned is glycoengineering, and this is one that I'll spend relatively little time about because it's kind of technical and doesn't apply to a lot of people. But there are some people that have a reduced response to rituximab because of genetic variants, and inebilizumab is designed to be able to circumvent this limitation, so it kind of enhances the ability for the drug to lead to B cell depletion. But importantly, there's a difference in cost as well. And inebilizumab is significantly more expensive than rituximab and its biosimilars. So that's something that needs to be part of the conversation when thinking about which one is going to be the best option for you. Fortunately, because it's FDA approved, most insurance companies are covering inebilizumab, and I personally have not had an issue with it being, even though it's expensive to the healthcare system, I haven't had it much of an issue with it being expensive out of pocket to patients. So that has been a positive experience that I've had, but it is important to recognize that there is that difference in cost. Now, I'd like to spend a couple minutes talking about side effects. In Mitigate, which is the trial that we talked about, there were more serious infections that happened in people who were treated with inebilizumab compared to people who were treated with placebo, and those numbers were 9% versus 3%. So it's not like it was terribly common in general, but it was more common in people who were treated with inebilizumab. Um, Weirdly, infusion reactions were more common in placebo than in inebilizumab. So that is definitely a reassuring finding and coincides with our thought process that inebilizumab should have less of infusion reactions. And we know that from data published in the other disease that inebilizumab is approved for as well. And low white blood cell count was also more common in patients treated with inebilizumab compared to placebo, and that's something that's not terribly unexpected based on what we know from other B cell depleting agents. So extrapolating from both these data and what we know from B cell depleting agents in general is that there is an increased risk of infection, in particular viral infections. We know that B cells and cells related to B cells are really important in responding to vaccines. So there is a reduced responsiveness to vaccines. That's an important side effect of inebilizumab. And low immunoglobulin or antibody levels in the blood can also occur. So we'll talk about these in a little bit more detail. First, we'll start with risk of infection. So this is because it depletes B cells, the way it's designed is once you get it, it's in your system for at least a few months. Or the drug is in your system for a few months, but the duration of B cell depletion is even longer than that potentially. it's not something that we can reverse. If someone has an infection or if someone needs a vaccine where they really need their B cells, we have no way of telling the B cells to come back. We just have to wait until the drug stops doing what it's doing. So these are things that we need to think about both before, during, and after treatment with inebilizumab. And most importantly, we need to be proactive about reducing the risk of infections. Vaccines are the most important thing, and we'll talk about that in the next slide as well. And the timing of when to do vaccines is particularly important. However, because it suppresses the immune system, it's really important to avoid live vaccines. And I've listed the common live vaccines that adults might get. Fortunately, none of these are commonly needed. Most vaccines that adults need are non-live vaccines. But it is important to recognize that because live vaccines have the potential to turn into the true infection, anyone who's on an immunosuppressing agent should not get any live vaccines. And it is important to recognize precautions such as wearing a mask, washing hands, trying to limit exposure to people who you know are sick whenever possible. I tell patients you need to be able to live your life, and that is true. So you shouldn't kind of isolate yourself from the rest of humanity and stay at home and do nothing. I think that is not in your best interest if you're treated with inebilizumab. But whenever possible, just trying to do common sense precautions to reduce your risk of infection is probably a good idea. And before we start inebilizumab, as is the case for many other medications, we do have to rule out exposure to viral hepatitis and tuberculosis before we start it. And if there is exposure to those, then they need to be treated before the inebilizumab can be started. Now, speaking about vaccines a little bit more, if the disease allows, it's important to vaccinate as much as possible before you start the medication. And that's because, again, the B cells that are depleted by inebilizumab are really important in actually producing the antibody response that we're trying to get with vaccines. The whole idea of vaccines is to tell the immune system, this is what the infection will look like in the future. You should create antibodies so that we prevent the infection in the future. But the B cells are really important in actually doing that. So when you deplete the B cells, vaccines that you get afterwards are just not going to be as effective. As long as they're non-live vaccines, they're still safe. So it's not like you can't get those vaccines, but they're not going to be as effective as if you were to get them before. Um, so and so that's before. After you start the inebilizumab, it is important to discuss timing of vaccines with your provider. And there's a lot of things that go into what those decisions look like. In some cases, we might wait to do certain vaccines until the B cells come back in the blood so that we know that there will be a good vaccine response. Some vaccines are time sensitive, like the flu. If you wait until after flu season to get the flu vaccine, then it's not going to be all that helpful. So in cases like that, we administer it really regardless of the timing of the inebilizumab. And if you're on inebilizumab for maintenance, meaning you're getting it every 6 months or so, and you need any vaccines in those settings, the vaccines tend to be most effective in the last 4 weeks or so before each dose. So you want to aim to get the vaccines around then, just to maximize the likelihood that your immune system will be able to have a good response to them. And here are the recommended vaccines. This is not different for inebilizumab compared to other immunosuppressing agents, but I think it's always worth going over. And these are for adults. I am not a pediatrician, and the vaccine schedule in pediatrics is much more complicated than it is for adults. So if you are a pediatric patient, I encourage you to speak with your pediatric providers to go over this in more detail. But for adults, it's recommended that you have a one-time pneumonia vaccine, which the most recent type of vaccine is called the Prevnar 21, but there are other regimens. So if you've gotten one of the other regimens recently, then that's usually adequate as well. Vaccinated against shingles is one of the most important things to do with inebilizumab. The risk of shingles is definitely higher in people who are B cell depleted. And that's a series of 2 doses of the Shingrix vaccine. Typically, that's supposed to be separated by 2 to 6 months. But like we mentioned before, it's really important to do as many vaccines as possible before you start inebilizumab. But at the same time, if you're starting inebilizumab, it's because you have active IgG4-related disease and you want to get it treated. So it is a challenge sometimes when we say, you need to delay the inebilizumab for 2, 3, 4 months until you finish getting all of these vaccines. So the recommendation is actually if you're waiting to complete vaccines before you start inebilizumab, you can actually separate the two doses by just 1 month rather than 2 months. And that really helps get the vaccines done sooner so that you can get started on treatment. I already mentioned the flu vaccine every fall. I recommend that to everyone, but particularly for people who are immunocompromised. And COVID-19 vaccine recommendations vary significantly between regions, between providers, and over time. But I typically recommend vaccination against COVID-19 every 6 months in people who are immunocompromised. So in people who are on maintenance on eculizumab, getting it every 6 months, I tend to recommend to plan to get a COVID-19 vaccine right around a month before each dose. And the last vaccine is RSV, which is recommended in immunocompromised people 50 years of age or older, and that's just a one-time dose of the vaccine. Now, I alluded earlier to the fact that there are different ways that we can use inebilizumab, and the practice patterns vary quite widely. We need longer term studies to better understand the risks and benefits. But there are some things that we need to think about when we use inebilizumab long term. And this is probably the most important one. The reason we don't necessarily treat everyone with IgG4-related disease with inebilizumab every 6 months for the rest of their lives is this. And this is actually data out of the trial done in the neurologic disease that I mentioned earlier, NMO spectrum disorder, where these were patients who remained on inebilizumab for a few years. And on the bottom, you can see the number of weeks that the people were in the trial. Um, and in the gray portion at the left side of the graph is when they could be on either inebilizumab or placebo. But after that, everyone was on um, in the open label extension, everyone was on inebilizumab. So you can see over the course of that open label extension, what this graph is showing is that IgG levels, which are antibody levels, the total number of antibodies in the blood, were gradually declining in people who were getting this medication. And this is the same phenomenon that we see with all other B cell depleting agents. The longer you're on it, the more the IgG levels fall. And those IgGs are antibodies that are meant to fight infection. So as the IgG levels fall, the theoretical concern is if they fall low enough, then it increases the risk of infection. Now, in this trial, they didn't see many cases where the IgG levels were extremely low or low enough that needed to be treated in any particular way. But the trend is pretty clear here that if you were to continue this indefinitely, it would potentially lead to that. So that's the reason we don't continuously B cell deplete everyone. And my approach, and again, this is something that your doctor might have a slightly different take, and it really is individualized for every individual patient. But my approach is that I treat most people with IgG4-related disease with inebilizumab, and I do use inebilizumab over rituximab for because of the differences that I mentioned earlier, and because it's now FDA approved. So I feel like it's the most appropriate thing to do when we have access to it. And the people who are treat with it are people who have multiple sites involved, if they have any internal organs involved, like the pancreas or the kidneys, or if they have risk factors for relapse. And these three things characterize the vast majority of patients with IgG4-related disease, which is why the vast majority of patients that I see, I do recommend treatment with inebilizumab. And how do I treat them is I do the 2 initial doses for everyone. In some people, I'll repeat another dose at 6 months, and those are the people who have either severe disease or an incomplete response after a few months of the initial treatment. And I'll occasionally do continuous maintenance every 6 months for people with particularly severe disease or for people who've had many relapses in the past. But I always think about the idea of when to stop it, or at least tapering or spacing out the amount of time between infusions. And that's just to try to balance controlling the disease with minimizing the risk of infection. So in summary, inebilizumab is a highly effective B cell depleting treatment for IgG4-related disease, and it is the first and only FDA-approved treatment for the disease. Most patients tolerate inebilizumab really well without side effects. But the benefits of disease control really do need to be weighed against the risk of infection that can happen from treatment over time. And vaccines and infection prevention measures are really, really important before, during, and after treatment with inebilizumab, as is the case for all other B-cell depleting agents. Thank you very much, and I'm excited to take some questions.
Well, thank you so much, Dr. Katz. That was an incredibly thorough, great presentation, and we did not get very many questions, but I do have two that I would love to throw at you. I know we're
Absolutely.
trying to keep an eye on the time also, so let me just go ahead with those, if that's okay with you.
Yeah, go ahead.
All right, so this is a very complex topic for patients, and I'm one of them, of course. So, what would you say to someone who says, "Why should I be excited or hopeful about this drug?"
Yeah, so I'll tell you why I'm excited and hopeful about this drug is it's our first and only FDA-approved treatment. Before we had this, sometimes getting people treated with even rituximab, which was the medication that had the highest level of evidence for it, even though it wasn't in a clinical trial. It could be very difficult to even get it approved by an insurance company because it wasn't FDA approved. Now we have an FDA approved treatment, and not only do we have an FDA approved treatment, but it's overwhelmingly effective.
Yeah.
I mentioned earlier 87% reduction in flare. That's not something that we see in a lot of trials in autoimmune diseases. So it is really, really effective, which is why I'm excited about it. There's reasons to have some concern. It does increase the risk of infection, and it would be lovely to have options that minimize that risk, but still keep the disease in check. Right now, it is the best option that we have for treating the disease, and it's the only one that's approved by the FDA.
Well, thank you so much for answering that. We did get one or two more questions, and I just want to ask you because of time constraints today. Is it
Yeah, that's okay.
okay if we get back with you and have a webinar just with the questions from this? That way we'll make sure we give each one of them the time that they deserve.
Yeah, I'm happy to do that.
Okay, that sounds great. Then that is what we will do. Sorry, everybody, if we didn't get to it. We want to honor Dr. Katz's plan for what time he needs to be off the webinar. And so that's what we will do, and we will make sure everyone knows when that is. So thank you so much. Before we finish up today, I just want to share a couple of things about the Vasculitis Foundation. Let me just do that real quick here. So as some of you do know about the Vasculitis Foundation website, but I just wanted to bring it up. I always like to do that as a patient myself so that you can understand how much great information there is there. For instance, under education, you can learn about the various forms of vasculitis. And as a matter of fact, after you've read all about the form, visit the section that says order print, and you can print out a short document that you can give to your family or take to your primary care doctor's office. I've been saying this for a couple of weeks now that I took mine to my dentist recently, so it was very helpful. I also want to just point out that we have this great new Find a Doctor tab that's just been redone. So many people don't know what doctor to go to or how to find them. So this is a great way to do that. It gives you the opportunity to put in which type of doctor you're looking for in the area that you live in to help you find the closest doctor. And finally, I just want to say thank you so much to Dr. Katz for spending his time with us, and thank you to the Vasculitis Foundation always for providing these webinars. And the last thing is, as you leave today, there will be a survey that pops up. So when you see the word continue, please click on that word and take the survey. That helps us with all of our future webinars, and we want to make sure we're covering the topics that you want us to cover. So thank you so much, Dr. Katz. We appreciate you being here with us.
Thank you.
Thank you, everybody.